Lecture 1 of Pharmacology Calculations. The purpose of this lecture is to give you a bit of the background as to how we've come about making changes within healthcare system as to how nurses administer medications. We're going to be looking at some error statistics. We'll be learning about the many rights that nurses follow to give safe, to offer safe medication administration. And then we'll be covering the medication order. So this information is all important as you begin to look at the medication order and then calculate doses based on prescribers' orders. So this varies every few years, but medication error has been anywhere from the 5th leading to the 8th leading cause of death in America. It's pretty staggering. About 1.25 million medication errors occur annually in the United States and account for about 98,000 deaths. What is horrific is that 3,000 to 6,000 of these annually are due to medication math error. So simple addition, subtraction, multiplication, and division. Medication errors costs our healthcare systems about $3.5 billion annually. They increase hospital stays anywhere from 8 to 12 days. And as many as 77% of them are preventable. So things that we should have caught, nurses should have caught, or the pharmacist should have caught, or the prescriber should have caught. Medication, by the time we're at the bedside administering a medication to a patient, there's at least three disciplines that have looked at the medication error. Obviously the prescriber, the pharmacy, and then the nurse at the bedside. We've done many things to try to implement improved systems. We look at medication error as a systems problem, not as an individual nurse's issue, although nurses can be negligent and administer meds incorrectly and not by according to the Nurse Practice Act for their state. So it's very important that nurses know and follow the guidelines for safe medication administration, and which you learn about in nursing school. So one of the things that we have put into effect is an electronic barcode system, and this occurs in addition to doing the nurses' checks. You'll learn about the 5 rights that we check specifically for giving the medication. In addition to that, we've instituted an electronic system. So a recent study at Brigham and Women's in Boston looked at the cost ratio of the barcode system to the cost savings that they've made in medication error prevention. And what they found was it cost about $2.24 million over a 5-year period, but the net benefit during the same period based on a decrease in adverse drug events from dispensing errors was $3.49 million. So quite a significant cost savings, as well as I'm sure this has prevented death and injury related to medication error. If you'd like to look more at statistics, this link right here will take you to some error statistics. So we do follow several rights for safe medication administration, anywhere from 5 rights to 9 rights, but there are a minimum of 5 rights that we check before standing at the bedside giving a medication to a patient. First off, we need to make sure we can read the medication order that is complete, clearly written. Orders are now electronic, which poses a whole different set of issues. As you know, with electronic orders, oftentimes there's a drop-down menu, and it's very easy to click above what the intended order was or below it. So there are many times we catch errors because the order is inappropriate for the patient, and that is an example of that. We no longer have to worry about deciphering a prescriber's handwriting. We have to worry about them clicking on the wrong medication. So we look for the correct drug, the correct route, and the dose, that the dose is safe and appropriate for the patient's age, the patient's weight. It's important for the nurse to have access to accurate drug information. We have multiple resources that give us this information. Administrative medication policies that are facility specific. That's very important. When you're oriented to your facility, that you learn these, you know where to access them. We administer meds safely, and we identify systems problems. So what does that mean? For example, if I'm working and I go to withdraw a medication from, let's say, a dispensing machine, and I see that there are two medications that look very, very similarly. Their label looks the same, the color is the same, but they are two different medications. That is a simple systems problem that could potentially cause a nurse to pick the wrong medication and make a med error. So identification of those issues and notification so that those potential errors could be averted. Nurses need to stop, think, and be vigilant when administering meds. Block out all of the distractions that we have. Nurses do get interrupted a lot. Things happen quickly. We might get pulled away from what we're doing. Another nurse may ask us a question or interrupt us, but we need to make sure that we set a boundary around ourselves while we are preparing medications so that we are very mindful when we're doing this. The good news is that nurses intercept 86% of all potential errors. That's a lot of errors that are intercepted. So we hear about these awful statistics, but we don't hear about all the potential errors that nurses avert. So I mentioned some of the rights for medication administration. We did not mention the right patient. Of course, that's critical. The right drug, dose, route, the time, the frequency, twice a day, once a day, AM, PM, before bed, first thing in the morning, every 6 hours, every 8 hours, things like that. The right recording. If it's not recorded, we don't know if it's been done. So documentation is critical. The patient has the right to refuse. So there are some exceptions to that rule that you'll learn about. If somebody is potentially at risk to harm themselves or others, we have the right to administer medications to calm the patient as needed. There are many ways we identify the patient as well as verbal. We have wristbands, so the patient is identified when they first come in the hospital. There are barcodes, a medical record number, and the account number are all on this. There are multiple barcodes on a patient's ID band, some for lab draws, some for medication administration, and then we have this nice rainbow assortment of bands that all mean different things. It could be a limb alert, it could be fall risk, allergies, so it could be that they're on a specific medication that is identified with a color. And here you see the electronic system where the nurse is scanning the barcode. The right drug. As you can see here, There's some great examples here of medications that look very similarly, but they are completely different medications. Same pharmaceutical company, but here we have hydralazine hydrochloride tablets, 50 milligrams strength. It's a multi-dose vial, 100 tablets, and then here we have hydroxyzine hydrochloride, and it's a 10 milligram tablet, but the label looks very, very similar, so it'd be very easy to remove the wrong medication. So we do what's called tall man lettering. You're going to see this where it, and you'll see it right here as well. So you see the ALA is all caps, and here you have the OXY. So it brings attention to the differences in the medication. There are often two names on a medication. There is the first and official name of a medication once it's made is called the official name or generic name. And you notice that here that these are the official names. There's not an additional name on these. Here's another example. Artemether beta artemether is the name of this medication. So these are all considered, this would be, this is just one single name actually. This is not actually a trade name. You'll always see after a trade name a RX after a little R after the name. There's always just one official or generic name, but there can be many, many trade names. For example, Lanoxin is a generic or official name. Digoxin is a trade name. So another pharmaceutical company creates a medication very similar in chemical formation to the original official medication, and but it is not the official drug. So, for example, digoxin would be a trade name. And you see the little R after it. Action letters are important to be aware of. ER, CR, XL, CD. These all, in this instance, stand for extended release, controlled release, where the medication is excreted in the body over a 12 to 24 hour period. We utilize things like the pharmacy, our nursing drug books. We look at facility changes, resources within the facility. So nurses, they get the drug, they prepare the drug, and then they administer the drug. The right dose. So this pertains to the unit of measure and the appropriate, let's say, milligram dosage. So it's a numerical value. So we have, for example, examples of some metric conversions here. Pharmaceutical companies recommend a specific dose. It may be based on body weight, or this might be a standard dose for an adult. Most pediatric doses are weight-based, as children can vary quite significantly in their weight. Sometimes it's by body surface area. So we make conversions. Sometimes if we have to cross-reference, let's say we have an order for 100 micrograms. When we pull the medication, it's in milligrams, so the nurse must make a conversion prior to administering the dose to make sure he or she has the correct dose. We use in this program dimensional analysis to calculate correct dosages. That's what we will be doing throughout the course of this class. It's important that nurses know and memorize the basic units of measurement. Some of the conversions for weight include kilograms to grams. So we start with the smallest, which is micrograms. and then to milligrams, and then milligrams to grams, and grams to kilograms. So there are 1,000 micrograms in a milligram, 1,000 milligrams in a gram, and 1,000 grams in a kilogram, capital K. So that's metric system, which is used solely for medication administration in the acute care setting or in the hospital setting. In other settings, if you're giving instruction for a patient to take medication at home, you might be converting these metric dosages to household measures such as tablespoons, teaspoons, ounces. So it's important for the nurse to be able to do that. As far as volume, with metric system, we look at the conversion of 1,000 milliliters equals 1 liter. And for body weight, 1 kilogram small k equals 2.2 pounds. Now, in some other countries outside of the United States, there are even more specific measurements. Or if somebody's worked in maybe food management, or they're a chef, they might use even more specific conversions. But as far as medication administration, to make things simple and easy to administer, we follow the measurements that are here on these next slides, as well as posted to Moodle in a PDF document. So you're going to print that document and memorize all of the different basic units of measurement for medication administration. So you will be required to know those so that you can calculate accurately. All right, we talk about safe dosage ranges. We look that up. Like I said, it's weight-based, or it might just be a numerical recommendation by a pharmaceutical company. We might see a divided dose. So let's say I'm giving 100 milligrams daily in 4 divided doses, or 25 milligrams every 6 hours. Okay, so that would be the same thing. BID is twice daily, TID is 3 times daily, QD is daily, or once a day. Sometimes our dosages are by weight, for example, milligrams per kilogram per dose, mics per kilogram per dose, micrograms per minute would be an example. And then dosages by diagnosis. So for a otitis media, this dosage is recommended, but for strep throat, this dosage of the same medication is recommended. Here we have an example of Tylenol 1 to 2 tablets every 4 to 6 hours as needed for headache. And it's important to know the tablet strength. Okay, we have a multi-dose vial here of regular strength Tylenol, and we see Tylenol is a trade name. We see the little R, and the generic or official name is acetaminophen. What's the patient's safe dose range? So 1 to 2 tablets, so that would be 325 to 650 milligrams every 4 to 6 hours as needed. The nurse looks that up, makes sure that's safe dose for an adult or whatever the patient's age is, and make sure it's not exceeded, because we're only held to administer medications with our Nurse Practice Act based on recommendations. Okay, based on evidence-based research on the medications. Here we have amoxicillin, 10 to 20 milligrams per kilogram per day. So that's a daily dose, and it's a range. Okay. If it's for a 100 kilogram man, so then you would easily take 10 milligrams times 100. So that would be 1,000 milligrams per day to 2,000 milligrams per day of amoxicillin. The last thing a nurse asks before he or she administers a medication is, does this make sense? If you have an extremely high number in the millions, or something that just is a red flag to the nurse, or you go to pull it and it requires greater than 3 tablets, that is a red flag to the nurse. Or it's an IM injection and the volume is 6 milliliters, that is a red flag to the nurse. So you always want to ask yourself, after you calculate your dose, does it make sense? And if nurses only did that 100% of the time, there would be people alive today that have been victims of medication error. The right route. So we have multiple routes. They are all listed here. You can look at those. It's important that you memorize these abbreviations for that. I do not take off whether it's capital or small letters. And this just shows the different routes. So, parenteral medications are medications given by injection, so not oral medications, but parenteral. So examples of that would be intradermal, intramuscular, or subcutaneous. An example of an intradermal medication would be your tetanus shot that, your PPD that you get yearly if you're working in acute healthcare or in a healthcare system where you could be exposed, you're more likely to be exposed to TB. So intradermal, which is a 15-degree angle right under the dermis of the skin, creates a bleb at the skin level with the fluid. Okay. Intramuscular is anywhere, typically a 90-degree angle. You see it goes through the intradermal, subcutaneous, and then into the muscle belly. And then subcutaneous is 45 to 90 degrees. And there are specific needle sizes for each of these, length and gauge that we look at. And examples of subcutaneous medications would be something like heparin for prophylaxis for DVTs or clots, or insulin. An example of IM medications could be an antibiotic. It could be a narcotic. Okay, so those would be examples for each of those. Another route is intravenous. Okay, so the IV route is a catheter has to be placed either into a central vein, such as the subclavian, or a peripheral vein in somebody's extremity. We can give IV medications by bolus or IV push. We can give them as a secondary or IV piggyback, where we hang fluids and then we slowly drip the fluids into the patient. So it's not by push with a syringe, but it just drips in slowly via these fluid bags and appropriate tubing. So we have primary tubing and secondary tubing. Some patients have electronic infusion devices that help deliver fluids at an accurate rate. And that is the most accurate method of delivering fluid. Another route is the intraosseous route, and that is used in the field. It's usually removed and an IV or central line is placed within 24 hours. So often it's the paramedics that are placing intraosseous route. So it's in the tibial plateau on the proximal distal lower extremity. This is a venous route through a scalp vein. Okay, that's an example of a scalp vein with a newborn. The right time and frequency are our last two rights, specifically for medication administration, that we look at as part of the medication order. So we look at timing. So the abbreviation for before is an A with a line over it. For after is P with a line over it. With is C with a line over it. Without is S with a line over it. Around meals, AC is before meals, PC is after meals. Stat, we don't see that anymore. We see now. They just write first dose now, and that means immediately at once. PRN, as needed, so a medication that you only give if it's needed. For example, if somebody's nauseous, we're going to give an antiemetic. If somebody's in pain, we're going to give a narcotic or an analgesic. So it's only as needed. We use the 24-hour system. If you click on this link, it will take you to that system. So it's important that the nurse be aware of the military time. So 1 a.m. is 0100, then it goes to noon, which is 1200, and then 1 p.m. would be 1300, 2 p.m. 1400, 6 p.m. is 1800, 9 p.m. is 2100. And midnight would be 0000 or 2400. These are the abbreviations I've mentioned before. H is hour. You can also see that HR, so either one. Every 2 hours, every hour of sleep, every other day is QOD, which is recommended be written out. The Joint Commission has made recommendations. Joint Commission is one of our governing bodies that accredits nursing facilities, healthcare facilities, and they make recommendations in the prevention of med error. So they are posted in your book. The page is listed in your syllabus for you to review to make sure you're aware of what should be written out and what shouldn't. For example, every and daily should always be written out anymore to decrease risk of error, because the Q does look like a 0, and this also could look like a 0, and people have died because they misinterpreted a Q for 0. These are the household measures that are important for you to know. Okay, and just want to bring up the grain system. This is the old apothecary measures where they measured medication by grains of sand by weight, and 1 grain was equivalent to 60 milligrams. If you think of a clock, it helps you remember this, so when you're asked to make a conversion, you can easily do that. So 1 grain, I think, is once around the clock, so it's 60 up at the top of the clock. A half a grain is 30 milligrams. Down here, a quarter grain would be 15, and 3/4 grain would be 45 milligrams. So I always think of a clock to help me remember that. Other non-metric measures include international units. It measures drugs in terms of its action versus its physical weight. So examples of this would include penicillin or heparin or insulin. It can be very small, it can be a very large number. So for example, 2 units of insulin, or it could be 5,000 units of subcutaneous heparin. It could be 1 million units of penicillin. So it's important that the nurse look it up, make sure that they know it's a safe dose. Another non-metric measure includes percent, and that stands for parts per 100, just like you learned in high school chemistry. The higher the percent, the stronger the solution. So 100 mLs of a 2% solution will contain 2 grams of a drug. Medications that are measured in percent include IV solutions, topical ointments, eye drops. So you see percent with those. Lastly, a last non-metric measure includes milliequivalents, and it's written out just like this with a capital E, and it's the number of grams of drug in a solution. And the most common, really I think the only medication that we measure in milliequivalents is potassium chloride. So 20 milliequivalents, 40 milliequivalents of potassium chloride. Like I mentioned, we use the metric system, although we might use household measures. But with the metric system, its simplicity is what is ideal for medication administration. All units of measure differ from each other in powers of 10. So conversions are accomplished simply by moving your decimal place either 3 places to the right or 3 places to the left. You must know your conversions to accurately make a conversion and know whether you have to go to the right or to the left. So if I'm going from micrograms to milligrams, and I know that there are 1,000 micrograms in 1 milligram, I know I'm going to be going to a smaller number. So my 1,000 micrograms, if I move my decimal place 3 places to the left to make a smaller number, I know that 1,000 micrograms equals 1 milligram. So the prefixes create the different values. We've talked about that: micro, milligram, kilogram. So kilogram represents the larger than basic unit. And as far as length, centi, milli, and micro are smaller than basic unit. So the smallest to the largest. Smallest to the largest. There are 1,000 milliliters and 1 liter. This is an example of a conversion similar to just what I did. For these basic conversions, we can simply move the decimal place. So 500 milligrams to grams, I know there are 1,000 milligrams in 1 gram. I'm going to a smaller number, so I'm going to move my decimal place 3 places to the left, and my decimal would go right here. So it's going to move to here. So now this would be 0.5 grams, right? If I'm going from grams to milligrams here, I know I know there are 1,000 milligrams in 1 gram. Once again, I'm going to a smaller number. My answer would be 0.5 grams equals 500 milligrams. So it's important to know your conversions before you can accurately calculate that. The right recording. So we use medication administration records. They're called the MAR, and now we call it the EMAR because they're electronic in most institutions. They allow for accurate documentation and communication of what's been administered. There are dangerous abbreviations, so we follow certain guidelines based on what's recommended by the Joint Commission or our governing bodies. So these are all considered unsafe, and we use these instead. Okay. And with zero rules, we always, if we have an answer that when we calculate it, we have a 0 at the end of it, 5.0, 10.0, we leave off the 0 because if that decimal is missed, that 5.0 becomes 50 milligrams, and now a patient is greatly overdosed. We call it death by decimal, because when there's an error related to a decimal because of the significant increase in the strength of the dosage that's administered, it can kill. We also accentuate a decimal by placing a 0 before a decimal. So if somebody misses a decimal, instead of 5 milligrams, they should have given 0.5 milligrams. So we always put a 0 before the decimal, and we leave off trailing zeros. Here are some order examples. We know we have the drug, the dose with the unit of measure, the route, the frequency, and whenever it's an as-needed medication, we have to have an indication. The pharmacy will call you back and say, this order is not complete. We need to know as needed for what. So it could be for temperature, it could be for pain. So there are multiple indications for this medication. Okay, so it's very important you have the whole order. Here we have the right drug, dose, route, frequency, as needed, and here we have moderate to severe pain. EC stands for enteric coated, aspirin, 325 milligrams by mouth daily. Everything is there. Cortisone, 30 milligrams by mouth 3 times a day. Digoxin, 0.125 milligrams by mouth daily. Demerol, 25 milligrams IM, and this slash means that it's mixed in the same syringe, so compatibility must have been proven. It's also included with 25 milligrams of Vistaril, so these two together potentiate each other and work for the patient in the indicated manner. IM every 6 hours as needed for pain. Heparin, 5,000 units, subcutaneous, twice a day. So we look at what's wrong with this order. We have Percocet, 1 to 2 tabs by mouth as needed. So there's no indication as to why. This should be for pain. And then it just says tabs. There's no dosage strength. So I would question, because I know Percocet comes in multiple strengths. Percocet has 2 medications to make Percocet. So I should have a dosage that has 1 dose, a slash, and a second dose. So I know the appropriate strength of that. Here we have the drug, the dose, the root is missing. Here's your frequency. We have Levoxyl, 0.10 micrograms by mouth daily. We're missing the 0 before the decimal, and we have a trailing 0, so we're going to add a 0 here and get rid of this 0. Here we have Coumadin, 2.5 milligrams daily at 6 p.m. So we have the drug, the dose, that we do not have the root. It should be PO. Regular insulin, we have a trailing 0. Units should be spelled out every morning. Hold for a glucose less than 100. And the root is missing. Subcutaneous. Regular insulin can be given IV, but not typically QAC. It's given in hyperglycemic events in a one-time dose, not typically every morning. Penicillin, 5 million international units, IV. Where's your frequency? It's missing. Nitroglycerin, 1% ointment every 4 hours as needed for chest pain, hold for systolic less than 100. We have an inch of ointment, but we don't have the dosage strength. Okay, we know how much to put on there, but we don't know the dosage of that nitroglycerin. So that's important to know. So here we have an example of a medication error. This was a little boy that was given the wrong dose of a growth hormone. So this little boy was at the lower end of, he was from Florida, and he was from the lower end. He was at the lower end of the growth charts, and they recommended at his age, this would be the time to give him some growth hormone. So the order was for this drug, 5.75 grams IV infusion. The pharmacy supplied it to the nurse in 2 bottles of 30 grams arginine per 300 mLs and labeled the bottles 1 of 2. So there were 2 bottles, 1 of 2 and 2 of 2. So what happened was that this dose was miscalculated to be, instead of 5.75 grams, they missed the decimal and they gave 60 grams, 57.5. Somehow they ended up giving 60 grams of the medication, and the little boy initially had a headache, pain, 4 hours later nausea and vomiting and seizures, had cerebral swelling, and later died. It's very sad. A decimal place contributed to the death of the. And then lastly, here's another case study where we have a little boy who was born with a ventricular septal defect. This was written up in the New York Times as an article about what do we do? You know, how do we deal with these situations where medication error kills innocent people? It was a very well written article, and it's posted on Moodle for you to read the whole article if you'd like. So he was under 1 year old. They wrote an order just like this: digoxin, 0.09 milligrams IV in a one-time order. So it was just a one single loading dose they were giving this boy to help decrease his risk of heart failure related to his ventricular septal defect. So it was calculated weight, base dose, and calculated to be 90 micrograms. Okay, so if we need to make a conversion here from micrograms to milligrams, I know there are 1,000 micrograms and 1 milligram. I'm going to go to a smaller number, and the decimal goes from here. So 1 place, 2 place, 3 places. So it should be 0.09 milligrams is the appropriate ordered dose. But what was given was 0.9 milligrams IV. So the nurse calculated it, showed it. The order went. I'm sorry. It was the. This was a teaching hospital, so the attending. Attending physician oversaw the resident. The resident wrote the order, miscalculated the dose, and wrote for the patient to give 0.9 milligrams IV instead of what should have been given and what was calculated by the attending doctor, which was 0.09. So the baby was given 10 times the ordered dose, and within about 30 minutes had died because of the effects of overdosing on digoxin. So it happens. There are many, many reasons that contribute to medication error. It could be staffing, it could be personal issues with the people that are working. The pharmacy short-staffed. The medication gets set aside and then up to the floor without proper policies being followed. So there are many, many things that contribute to medication error. So every day we go into work, we have the potential to harm as well as help people. So it's very important that we do everything we can, and if that means learning a specific method of dosage calculation, if that means making sure we get adequate sleep before we go into the hospital, if that means making sure we don't let people distract us when we're calculating our medication dosages, if it means waiting and making yourself call the pharmacy or look something up to double check, listen to that little voice inside your head that says this is a red flag. All of those things are important to do before we administer medications. So this hopefully gives you a background as to why we place so much importance on medication administration. It's one of the most common skills that we do is administer medications, and we hold much responsibility with our role, and it's important that we take it very seriously. Okay, thank you very much.